Hello and welcome to the webinar. My name is Megan Nicholson and I'm the Director of Marketing at Wellbe. We're happy you've decided to join us today for improving the patient experience for joint replacements by using a guided process. A few housekeeping details before we get started. This webinar is being recorded and you should receive a link to the recording and the slides tomorrow in your email. Please feel free to share this webinar with colleagues who could not attend today. A question and answer session will immediately follow the presentation. If you have a question for our speaker, please type it into the questions box in your GoToWebinar panel on the right side of your screen. Today's webinar is sponsored by Wellbe's Guided Care Paths. A guided care path helps automate patient preparation and follow-up activities through the entire episode of a total joint replacement, allowing visibility to patient activities outside of the hospital. Key check-in points along the surgery journey can provide risk flags for patients who may be off track and require intervention to avoid additional costs. Reports give administrative insight into how their programs are performing. To request an executive briefing on orthopedic service line automation and how it could help your joint replacement program, please visit us on the web at wellbe.me. Now I'd like to introduce our speaker for today. Julie Benz is the Director of Outpatient Therapy Services at Avera McKinnon Hospital. Julie has been employed with Avera Health for 30 years. She received her degree in physical therapy from the University of Iowa and master's in administrative studies from the University of South Dakota. Julie, I'm going to turn it over to you, and you can take it away.
Thank you, Megan. Just checking to make sure it's all up.
Yes, looks good.
Okay, great. Thank you. Well, thank you, everyone. Thank you to Wellbe for allowing me the opportunity to share our journey at Avera McKinnon on improving our patient experience, particularly in the joint replacement arena. You may kind of say, why is the Director of Outpatient Services presenting this? Well, just recently my role did change to focus on an outpatient basis, but previous to that I was actively involved in inpatient nursing and therapy services both on an orthopedic, neurological, and rehabilitation basis. And so a lot of the work and things that are being presented were done by my team in hopes of improving the patient experience with successes that have occurred and continue to occur at this particular point in time. Just a little bit about our facility. Avera McKinnon is located in Sioux Falls, South Dakota. It is part of the Avera Health System, which is an integrated health system of 6 different hubs throughout South Dakota and Minnesota. Avera McKinnon is the largest of that hub and was established over 100 years ago. Just a little bit of information. South Dakota has about a population of 700,000. Almost 200,000 of that is in the immediate service area for Avera McKinnon, and the other top competitor of healthcare within the state is just 12 blocks from our hospital. Both facilities are very competitive and are able to provide the top-notch, state-of-the-art services to our mostly rural healthcare environment. About 37% of our patients are from this immediate area, and 63% come from farther than 60 miles away. As you can see, that's where little Sioux Falls is at. It is on the very far eastern tip of the state. So we have referral sources and patients coming from southwest Minnesota, Iowa, Nebraska, and throughout the eastern part of South Dakota. Within the Avera McKinnon network, or just our little hub, we have 13 regional hospitals that we continue to support. On the left side of the screen, you'll see our Avera Behavioral Health Center, which is a state-of-the-art behavioral health facility that maintains inpatient and outpatient therapy services, behavioral health therapy services, as well as physicians. It's a 100-bed facility. And right next to it is our specific heart hospital for cardiac care. We also have 85 primary and specialty care clinics in our region. We have been blessed to have been sponsored by the Presentation and Benedictine Order of Nuns, and which has given us and helped us ground in our faith and in our mission throughout every bit of work that we do. And because of that, we have gained national recognition for excellence in a number of areas, including orthopedics, but extending into other areas of cancer treatment, pediatrics, etc. Our mission is that Avera Health is a ministry rooted in the gospel. And our mission is to positively impact the lives of the people in our community, guided by Christian values. And again, that kind of continues to drive why are we so driven to do more and more and better things for our communities. Competitive spirits, such as having a competitor, again, another top-notch healthcare facility not far from us, is the fact that both of us have and maintain excellence in clinical practice. The one area that we want to continue to build and grow and excel in is in our customer service and how best we can do that, because that will be the differentiator for us and our patients. Our vision is to continue working with partners to provide that quality, high-cost or cost-effective health ministry, and how do we improve that healing care and healthy living. And when we talk about partners, those partners are our patients, their families, our physicians, partners such as WellBe, and other providers and partners in our delivery of care. And our aspiration is really through that service and process excellence. Avera McKenna leads the nation in high-quality, affordable health care. And it's really those two integrated things, that the service side of things and the process excellence side of things, that help direct everything that we do. I always think about in our particular area where we have people coming from remote, very remote locations, how can we easily access the individuals that are receiving our care, as well as how can they access us? And we have been, Avera McKenna has been a leader and recognized for the use of their e-services, which was able to allow us to have e-pharmacy, ICU, e-emergency, e-stroke, out in the rural communities that some of them may be 45, 50, 60 miles away from the nearest healthcare provider. That also creates a challenge for us as we're looking at orthopedics, and how do we make sure that they have the same information and can get the same information in a way that without having to travel here. We implemented a joint camp in 2002, and part of that process was to have our patients come to our facility for their pre-operative education. And what we were finding is that it was very inconvenient, very costly for those individuals in the remote locations to get here. And so tried other methodologies of using the educational material and sending it to their home. That became quite costly. We've looked at a number of other different ways, but either the technology was not available to the individuals, the distance still to get to the location that we could provide those services at was still unattainable. And so really continue to use all the innovation that we have to try to bring information to our consumers prior to, at, and post-discharge, so that we can continue to monitor their progress and improvements. We strive to be that forefront of innovation. E-services assisted us with that. We were very early on adapters of hospitalists with that. We have been early adapters of many clinical practices, trials, research here in our rural community, and how it impacts the rural parts of the United States. We have been recognized as one of the top 10 trailblazing hospitals and have been on the list for the most wired for using electronics for almost 15 years. When we kind of looked at what are we trying to achieve is always goals determine what you are going to be. So we really went back to establishing what our service excellence goals were. And to be perfectly honest, we were not being very successful when we looked at HCAHPS scores, or when we used the Press Ganey at one particular point in time, and we just were not hitting the benchmarks that we wanted to hit. We could hit the quality initiatives, we could hit the quality benchmarks, but our service, and we had tried multiple methodologies of getting that across. And so we decided that we were going to set small, realistic, attainable goals, always looking at what our ultimate goal is, which is, again, to create that, be the highest in quality and service provider that we could be. So with that, I want to share with you a little bit today about what problems that we identified, particularly in the orthopedic unit. It was not always just with the orthopedic unit, and how we implemented those across our whole organization, and then to identify some innovative concepts that we use to improve the processes to achieve positive outcomes. Oops, excuse me. Just a little background on our orthopedic unit, just to put things in perspective. We are a 32-bed unit. Last year we did about 700 joint replacements. We have two primary orthopedic groups. One, neither of them are employed groups. They're both independent practices. One having 3 physicians that do total hips and total knees, and one of those groups there's 8 orthopods that does total joint replacements. In 1987, we established Easy Street, so our facility has a small area that has been set up as with an apartment, a bank, a movie theater, a grocery store, things that can replicate community barriers or community facilities that people would use. We did this primarily because a good chunk of our time is in rain or snow, and in this area, and so it gave us the opportunity to put real life experiences to our patients. That also has been, that was one of the, we were the 3rd one in the United States to have that, and that allowed us the opportunity to differentiate ourselves, and people did, that was a good experience, and allowed them to try it prior to going home. It created increased comfort for the family. As I said, in 2002 we initiated Joint Camp, which again was a very positive thing. We saw our numbers grow for our total joint replacements that each year with the implementation of Joint Camp, and the streamlining of the process made it consistent for all of our patients that were coming on board. Physicians knew what the process was, nursing, therapy, and it maintained and became a standard of care to ensure that all the quality measures were being met, as well as expectations and outcomes for the patient prior to discharge. Some of the challenges, as I said, though, we're in a very competitive environment, and so every opportunity to make a difference was really focused on how we change our customer service. We had some reducing volumes for a period of time. There was also the addition in this time frame of a freestanding outpatient surgical hospital just across the street from us, which I know in talking to colleagues across the country that those also popped up in their environments and had a dramatic difference. And in some cases, that meant that the population that the hospital was getting was some of the more complex and difficult patients, where education and awareness and understanding of risks, as well as expectations prior to discharge, may have been a little bit higher. Our patient satisfaction was below the top box performers, and that was not acceptable to us. Our quality outcomes, we were doing spectacular in many of our outcomes, and actually all of our outcomes except for 2 areas, falls and pain management. And as we are challenged more and more to manage both of those items, for not only for patient satisfaction, but from a CMS and risk perspective, it took a higher priority. So some of the things that we looked at, and I'm going to share with you in the next few slides, are things like process excellence, our use of lean technology and lean principles to help us in increasing our efficiencies for the nurse so that they had more time to do some of the other things that they needed to do, i.e. education, monitoring the patient to reduce the numbers of falls, and try to manage the pain. Excuse me, the pain. We also did purposeful hourly rounding, leader rounding. We had the development of the pain team with a one-call response, and then we had implemented the Total Care patient guidance system, and we'll go into each of those a little bit in more detail. It was probably about 6 or 7 years ago that Lean was introduced into our organization, and it was introduced as part of a construction project. A new director or leader in our organization came forward and said he had been certified in the Lean process and wanted to do that to help improve the flow, efficiencies, and reduce costs in that particular development of a location. And with that, Lean continued to grow and develop, and 2 years ago, we implemented a Lean team on our orthopedic unit. Our orthopedic unit was built in the 70s in a spoked model, which is not really conducive or effective, but it is what we have. And so really looking at how do we make sure that we have the supplies that we need at point of use for the nurses. So with the use of our nurses, our leadership team, and our experts in Lean, we implemented visual management controls that allowed us to have all the equipment that we needed at the bedside. And I take that back, not all of the equipment, but at least the key pieces of equipment or supplies that were needed so that the nurse had the opportunity to stay right with the patient at their bedside to do most of the activities that were required for a total joint replacement. This also transpired into all of our other units as well as other patients not a total joint on the ortho unit. So we use things like shadowing and labeling, and-on signals, downtime clocks, and process control centers to do that. For those of you that may not be familiar with Lean, we did a lot of double binning. We really looked at, we had supplies all over, which also led to inefficiencies with outdates. We also had a lot of stock that was more than we really needed, so we were able to reduce some of our costs. But the key thing for our patient experiences is the nurse was not going in and out, in and out, in and out of the patient room. They were able to maintain there and have all the supplies, do it in a quick fashion, and could focus on what the task at hand was with the patient and educating them at that point of service. These are some of the tools that we used. As you can see on the left-hand side, we have our computer station, and we had carts made. The left side of the cart was the nurse's side of the cart, which had supplies. The right side of that cart was the patient supply items, toothbrushes, socks, gait belt, those types of things that would be used for the patient comfort, left side for the nurse's comfort. And then again, also had all the equipment there and restocking, which again, saved costs and kept people right where they didn't have to go looking for anything. We then implemented purposeful hourly rounding. And before I get to this, I do want to say that at one point in time, we were trying to implement too many things at one time. We had read a number of different books, talked to a number of different facilities that implemented specific strategies, and thought, okay, let's just go for it. Let's get it done. That wasn't successful at all because we could not hardwire that with our nursing staff, our clinical staff, and our support staff that come on therapy, nursing, lab, pharmacy, radiology. So we did step back. We stepped back and said, you know what, it's not working to do everything at one time. So we took a moment and then identified what parts that we could do when. And so this is a phased process that we did and have been much more successful with phasing it in and giving them the appropriate amount of time to make sure that it is hardwired. So anyway, we implemented purposeful hourly rounding. We used the visual management controls of the flags outside of our room so that we knew if the patient was out of the room. If we had completed an hourly rounding, and we used the green flag to show that we did the round on the even number and the yellow on the odd. And that seemed to work fairly well. And I'll be honest, as we implemented this before and it was not successful, it really took a lot of effort and work, education, and follow-through by the leadership team of the orthopedic unit to make sure that it was occurring in a real-time, regular basis. We had the support of our patient services representative or our health unit coordinators or secretaries. The terminology may be different in different facilities. But them also, by looking down a pod, they were able to identify who and who had not been rounded on that particular hour and were able to follow up with that. This seemed to be well received by the patients, and pretty soon the expectation was that someone would be in, and the nurses were communicating in a consistent manner what their plan was for the day, and the patients helped in keeping our staff accountable to that as well. And that was very helpful, and we set expectations with the patients that they should expect that, and that if they hadn't, please communicate that with their nurse. And we found that that was happening on a fairly routine basis. From there, we moved on to intentful leader rounding, and with that, what was happening is that we set an expectation that the leader would meet with our staff. They'd touch base with every staff member daily as they started their shift or sometime during their shift. They would observe them in using what we call our care standards of communicating a positive attitude, responsiveness to the patient, and engagement with both their patient, the physicians, and their colleagues. And they would follow them and touch base with them on a shift-by-shift basis and be able to coach in the appropriate manner on a real time. They also would sit down quarterly with every staff member for about 10 minutes, and we asked 4 simple questions for them. What's going well in your day? What are opportunities to improve the efficiency and flow of your day? Are there any equipment needs that you feel need to be met? And then the last one is there any of your colleagues that you would like to recognize for going above and beyond in the support of the care standards and our initiatives? And that was done every quarter with each staff member. And again, that one-to-one, it wasn't a lot of time, but it really gave that one-to-one attention with the patients. And in the past employee opinion survey, you can see where that was identified as an improvement area where they were able to view their concerns, feel like they were being heard by their leader, and the leader was able to do some one-to-one follow-up with them on that. And then we implemented senior leadership on a weekly basis where the senior VP of Patient Care Services, the CNO, our facilities director, our chief medical officer, as well as the leaders on that floor would meet on the floor, and they would talk about what were some of the successes and outcomes. They would help them problem solve and where there were challenges, and those things could be identified and addressed in real time, face-to-face fashion. That continues to this time, and staff now are engaging in that same what we call a huddle, where they come to the huddle as they're able to have that interaction with our senior leadership team. We also, as I said, pain management was also a concern, and so at this particular point in time, we worked with the other surgical unit to identify a pain team. We have a dedicated anesthesiologist and a pharmacist who round on all the patients their post-surgical, first post-op surgical day, and really look at the pain plan for that particular patient. They also are available. We have a one-call number where if the plan that they have put in place isn't working throughout the day, they have one number that they can call, and a pharmacist or the anesthesiologist or one of their identified representatives will work up with the nursing team on that particular patient's pain management regime. We also have a pharmacist directly on the orthopedic floor and every floor within our organization during the day, and then one available at night for those same types of issues with the medication review and recommendations that have been established by our physicians and are readily available to our team. The other part is that they put together a pretty comprehensive list of non-pharmacological, intervention, when I call interventional, of like for therapy or some other type of intervention. They put in things, comfort methods like heat, massage, distraction techniques, etc., that are available to the nursing team as well. This seems to have a number of different positive benefits. First of all, the team knows all the nurses on the floor, and they're able to interact in a really professional, face-to-face conversation almost every single day that the patients are there. And so they all get to know each other and respect what each member brings to the team versus having to make phone calls for each individual their physician. The pain anesthesiologist has really taken on some of those primary roles after the procedure has been done. It has been a work in progress with the physicians, but has made huge inroads and gains to where most physicians are using the pain team to manage their patients' post-surgical pain. So this has been a very, very good thing. It's also reduced our medication costs for most of our patients. The other thing our organization did is we have a very robust genetics and genomics research team, and they are currently working on research using specific criteria, but patients who are having total hips or total knees that meet these criteria, they will do a genetic testing which will help them identify which pain medications are metabolized best by that patient and helps then us guide and direct what may be the most effective pain management regimen for that person. It is in its early infancy stages, but some of the early results have been very, very positive. One of the big things that we were challenged by is, though, and a lot of dissatisfaction had to do with communication of what the expectations are, information on who was providing the care, discharge planning, what the patient's intent was before they got here, and what our intentions were for those patients once they were here, and how do we share that information best. And this was really a challenge for us. There are so many interactions that happen with that patient on a daily basis that we couldn't always be real consistent or congruent on what information they got, when they got it, and were they able to keep that information in the forefront, and were they able to communicate it to their family members if they weren't there. In looking at the advisory board, they had said to shoulder greater accountability for outcomes, healthcare systems must close that gap in communication and coordination with managing that care, and it has to go beyond the acute care setting or the physician's office. And in looking at that, we were like, how do we do that? We can control when they're here, but we can't always control when they leave here or before they get here. And how do we get the information? Some of the things that we've been doing have not been as successful as we had hoped. Sometimes the information we were hearing was overwhelming and they had it, but they really hadn't read it. Or, yeah, they thought they read it, but they really didn't understand it. Or it was just a lot of information for them. In 2012, our Senior Vice President of Marketing and Innovation went to a conference and met up with the representatives from WellBe and brought this information back to us. She knew we'd been struggling and we had been looking for methodologies to improve upon that. And she brought back Welby to Avera McKinnon. And we were able to talk with Abe and James from Welby, and we were able to say, this is something that I think would work very well. It was a guided path which allowed us the opportunity to use our input, allowed us to help in developing and putting into a platform that had been established by Welby, a method for getting the right information to the patient at the right time, and also being able to have the patients access that information and or their families access that information at the time that was best for them. And so we launched in February of 2013 Avera Total Care, which was guiding our patients through their joint replacement. The program, when it initially started, was a work in progress. It was a collaboration between all the different entities and partners that bring the care pre, at the time of hospitalization, and post together to kind of look at what information are we providing, how do we know what the other people are asking for, and what information the patients are giving, so that we, one, don't create redundancy in asking for information, because that was a huge patient dissatisfier. Two, we were able to go back and get that information at any point in time and modify it as we needed to. And the third thing we knew we were able to do is to provide that information not only to the patient, but anybody that they designate that could support them in their journey through their total joint replacement path. And so Total Care was launched, and our goals were that we wanted to improve that patient experience. We wanted to ensure that the patient adopted and became engaged with our total joint replacement. We wanted to make sure that our satisfaction scores went up. We wanted to look at how do we drive staff efficiency, because we were having 2 or 3 people going in and talking to the patient about the same thing, but giving maybe just a little difference in the information based on what their specialty was. And this was a way in which we could create a consistent message bringing forward, and we could create a compelling competitive differentiator. Our competitors don't have this program. So I'm going to share with you a few of the screenshots of Avera Total Care. And I just want to share that this, again, was a work in progress. It was identified and launched in a very, very short period of time based on the platform that was already established, the technology, as well as commitment from our team and taking the information that we were all providing and putting it into this platform. One of the things that is also so key about this particular program is that we were able to determine at what point in time does a patient get registered for a surgical procedure, at what point in time do patients need particular information, and how do we get them that information. So, for example, identifying what you need to bring to the hospital shouldn't occur if our time from schedule to surgery was 4 weeks. At what point in time do we give them the information on what should you bring to the hospital? And at what point in time do we give them the information on what is your discharge plan? And at what point in time do we ask them to fill out their registration information prior to their nurse calling for pre-admission? We were able to determine all that based on data that we had, and we're able to input that into the system. The other beauty of this system is that we were also able to tweak that system. Working with the WellBe team, they were able to take our input. We met on a weekly basis, a phone conversation on a weekly basis, so that we could look at what our outcomes are with it, what our utilization was. We can look at this was working or this isn't working. And we have a community educator who helps us in doing all that. She was originally with our joint camp program doing all of our, not only community education sessions, but she was doing all of our preoperative teachings. She was also doing all of our follow-ups. She was the one mailing our booklets and trying to make sure we had those booklets. And our costs for that were continuing to rise too. So again, we were trying to look at how do we minimize our costs or reduce our costs, get the information out at a time when the patient is prepared to get that information, and how do we make it readily available. So with this, they are able to track their progress, and we have it broken out by pre-surgical, so from the time that they go into the physician's office to the time that they come into the hospital. There's a component that's hospital when they're in the hospital. There's a component that's post-discharge, and then we continue to track their outcomes up to 1 year post-surgical. This was also a great tool for our physicians clinic because we were trying to look, as we looked at centers of distinction, we didn't have a lot of information on what was the long-term outcomes of those patients because the patients weren't, the physicians were not employed by us, and we didn't have easy access to that information. Now we do through this process is that all the patients come through. One of the challenges that we have, and we had, and we still have, is that to maximize this, being able to start this process in the physician's clinic on the time that the surgery is scheduled would be ideal. But that has been challenging for us with independent practitioners and because of the volumes of patients that they are seeing. And so we initiate the process on our end when we get a booking sheet for a surgical intervention. But we are able to then just continue to track and see WellBe launches the education when we've asked them to launch it, and then we can track and see who's been in, who's signed off on the information, what information they've given. We can, all of our team members from pre-admission to our ambulatory unit to the nursing to our social workers and therapy can all go in and get that information that's out there so to help them plan and prepare for that patient's stay. So as you can see, they have a guide, they have their journey, they're tracking across the top, and then appointments that they have, because we can put right in there their post-discharge appointments with who it is at, where it's located, so it's all at the ease of a fingertip. The other part that's very nice about this is that the patient can identify those care members that they would like as part of their care team. So in our rural states, we have a high elderly population, and some people are not comfortable with the technology of computers. However, their children or grandchildren are. So they may ask them to support them in their journey, and that has been effective for many people. At this particular point in time, again, knowing that we have a more rural community and not everyone is using the technology, we have about 45 to 50% of those patients that are registered that actually take the and use the Total Care package. But what we're seeing is that as we make changes to this program and as the updates are happening, this is version 2. There is higher utilization and access. And I think we anticipate that this will only continue as our population is having total joints at an earlier age and as the technology age continues to advance as our population gets older. These are some things. This is another screenshot of one of the tools. Like I said, things are launched at different points of time so that they can access it so it's not overwhelming. And this is one of those for the plan for the day before surgery. You know, things like packing your bag, and it goes over some things that they want to remember to bring and not to bring. You know, reviews the eating and drinking instructions prior to them coming in or directions how to get here. So trying to give that information, and it launches. This can be used on their iPads, can be used on their computers, can be used on their cell phones. We also use the same technology when patients do still come in for our pre-op teaching if they're in the area, and our community educator uses the technology, an iPad or a computer, to show them how to easily access information now and in the future. A lot of this, the information too, is customized. So as you can see from this report, Dr. Eric Peterson is one of our orthopedic surgeons, and his face appears there, so it creates recognition. Some of our patients have only seen their physician at their when they decided to have surgery and are like, oh, I don't remember kind of what they look like. This is one way in which we can continue to give them visual cues on who their care team is, their physician, the PA or nurse practitioner who may be working with that physician, the community educator, their social worker, etc. And so everything has been customized to that, as well as we're able to give interactive messages through video clips and linkages to other things within our website or in our resource library. There also are a lot of different programs that can be used for us to track information and look at information that we feel is important, whether it be for us individually for our program or things that we're tracking for CMS or meaningful use guidelines. And most of these are very quick, easy, point and click type of surveys that are being done, and then those results are tabulated on the backside, and we can manipulate that information so we know if it's by total hips, total knees, what time frame, how many filled it out, how many had that we were controlling their pain minimally, mildly, moderately. And this continues to evolve and helps us in really looking at what data is important for us, and allows us the ability to just focus on that and not have to dig through a lot of information. Here's an example of our library. A library is where we're able to put different resources and different information that we want available to the patient. We have two of our physicians who use aquatic therapy post-op day 1. The patient's total hips are in the pool post-op day 1, and they continue doing that upon their discharge if that is available. So it's not on a standing for everyone, so we have it in the library so we're able to go out there and they're able to gain and garner more information about aquatic therapy and the benefits or pain medications, etc. So we try to put those most frequently asked questions in some sort of information in our library and help in directing the patient and their family members to that library to avoid unnecessary phone calls for the staff that may come in afterwards, or for the clinic that may come into the clinic side of things, and continue directing them to our library for information. I spoke a little bit before about the care circle, and as you can see, here's an example of a care circle where the patient is in the center of that circle, and around that circle are their providers. We're able to pretty easily identify our care coordinator as well as the physician and his assistant. They're linked together. The social worker and nurses, physical therapists may change day to day. However, we are able to add pictures into those particular care circles as we go. This is also where the care team is able to identify who the patient has put as part of their care circle, what family members are part, so that we also can link in with the primary person that the patient is looking for. I spoke about reports, and honestly, the reports are so numerous to mention, but valuable information has driven our process, whether it be to tweak the Total Care program, or whether it has been to educate, change our processes in the hospital side. We've been able to look at one of the examples that we were just talking about was our pre-surgical assessment a year and a half ago was done with a nurse calling our patients, and it taking about 45 minutes because the patient had to go get their medication in their bottles or needed to find some information, and a nurse, pre-admission nurse, could be on the phone for about 45 minutes. We put together a tool that the patient could input the information, and then the pre-admission nurse could pull that off. Well, it was challenging because at the same time that process was going on, they were putting on our website a link to pre-admission information that the patient could do on the website, so they were going there instead. through this whole process, we were able to link both of them together. So in one easy step, everyone had the information that we needed. But it wasn't until we got some of the reports that we were able to identify that. This is kind of small, but it is able to look at, we can run things by date, by time. We can look at new enrollments coming in, how many of those people who were enrolled to have surgery actually registered into the system, you know, how many times they went into there, how many had completed certain activities, the surveys, etc. So it gives us a tool where on a weekly basis we were going back and kind of reviewing where are we being successful, where are we challenged by. It also, if you look at the bottom, we could break it down by who were those enrollments, registrations, so the information could roll up all for a summary, but we could break it down bit by bit so we could dig into that and look at what was going on and what were some of the challenges that our patients were facing. Again, this is another look at how that report can come out. So depending on how you want to or where you want to share that information, it is all right here. Again, some other changes that we made in this whole process is that we started aquatic therapy post-op day 1, which has had overwhelming responses, and we've had additional physicians who have implemented that process. We also added a dietary aid on our floor 8 hours a day to assist with nutritional needs of the patient and making sure that their trays were getting there on a timely basis. We do not have a restaurant type of order and delivery, which is something that is a goal of ours as well. But this individual became very familiar with the likes and dislikes of the patient, and would frequently go around and making sure that they had the nutritional and liquid supplements that they needed. We also implemented daily rounds with our care team of RN, case manager, social worker, therapy, and physician liaison, so that we were all on the same page, and goals for discharge were progressing as identified either in the plan from the patient's perspective or helped in communicating what the changes in the plan were based on their hospitalization outcome. So what were the results of our efforts? We saw a dramatic reduction in our falls, and we attribute it to a number of reasons. One, we were able to do a little bit more pointed education in fall risk. We were able to identify a little bit easier and a little bit more consistently and prepare for those patients that had fall risk even prior to them coming into the hospital. By giving the patients more information, it required less education and less pulling of information for the patients. We could refer back to their total care program, which allowed the patients to, the nurses to be more accessible. And by also using the tools, the lean process with point of use supplies, the purposeful hourly rounding, etc., we were available, observing, and anticipatory of those particular needs. We've attained, we started off and the staff were like, this is not attainable. You know, our goal was to hit no falls. And the staff were like, well, that's not really applicable with a geriatric orthopedic patient. And our highest number of days is 72 days without a fall on the orthopedic unit. And the heightened awareness of that also increased their utilization of the purposeful hourly rounding, the use of the total care for education for both the patient and the family. And so we were, and with pain management, being able to manage the patient's pain better, they were more comfortable and would not take unnecessary risks. So this benchmark continues to come down. It's slowed off quite a bit right now, but one of the things that we've also identified is how do we, as we onboard new nurses, how do we instill and ensure that the importance of all of this is brought on through the onboarding process. Our patient satisfaction improved in all of the areas, and I am not in the area at this particular point in time, but when I visited with my colleague, the most recent survey, again, continued to show increases in these areas, just slow and steady. Our goal continues to be in the top 10 the top 10% of the patient satisfaction, and we have not attained that as of yet, but we continue to head in the right direction, and we continue to celebrate those successes. Our surgical growth continues to increase. As of yesterday, in July, we had our highest surgical volume for any month in the history of our organization, and our orthopods were in the top 12 of those surgical cases. So our orthopedic volume continues to grow, and because of a number of factors, I believe, Total Care being one of these, is that we continue to provide the things that the patients are looking for, and they continue to seek out our organization as their choice. We have been recognized by Web Health Awards in 2013 for our Avera Total Care package. We have received in orthopedics in 2014 Health Grades Awards for our 5-star awards. We're in the Proven Health. We're in the top 100 hospitals. We were the first #1 hospital in South Dakota in 2012, 13, 14 by U.S. News and Report and Premier's Quest winner. We also are, we excel in excellence, and that continues to be what our goal is. We are just right now. We'll be having a site visit for our magnet redesignation. We are the 36th in the country, and we are just going to be having our site visit for our 4th redesignation, our 4th designation, excuse me. And so very proud of the things that we do, and we appreciate partnering with entities such as WellBe. We appreciate our colleagues and the ability to seek out information on what's being successful to them, and we like sharing what our successes have been and what journey we took to get there. So with that, if there's any questions, I'll be happy to entertain questions.
Thank you, Julie, for that informative presentation. We will now open it up for questions. If you have a question for Julie, please type it into the questions box in your GoToWebinar panel on the right side of your screen. While attendees are submitting questions, I want to remind everyone that today's webinar is sponsored by WellBe's Guided Care Path. A Guided Care Path helps automate patient preparation and follow-up activities through the entire episode of a total joint replacement, allowing visibility to patient activities outside of the hospital. Key check-in points along the surgical journey can provide risk flags for patients who may be off track and require intervention to avoid additional costs. Reports give administrators insight into how their programs are performing. To schedule an executive briefing, please respond to the poll on your screen. So, Julie, our first question is from Sharon, and she wants to know who creates these reports and gives you all this data.
Great. This is we have had weekly, as we implemented and as we launched and continue the process, we have weekly phone conference calls with representatives from WellBe to look at the reports that we want to have developed and created. And in a collaboration with WellBe and our care coordinator, they're able to generate and pull these reports on at any point in time.
Great.
That answers that question?
Yeah, we have some people who would like to know a little bit more about your aquatic therapy on post-op day 1. Can you describe that?
Sure. We have a physician that's very assertive, and we have a therapeutic pool right in our hospital. And so post-op day 1, the patients are transported down to our pool and we have lifts to get them into the pool, but they start doing walking and some gentle exercises, and throughout their 3 days of stay, they receive aquatic therapy 1 time a day and then land therapy once a day. And then from there, we can just continue with aquatic and land therapy to work on good gait patterns, strengthening of muscles, and it does it in a very pain-reducing medium, which has been very well received. It is not one of those things, however, that all physicians approve of. We have demonstrated our pool water clarity, and we have had no infections in the pool. At this particular point in time, we cover the surgical site with an op site, and we continue to just have people go in, and now we've just increased to our second physician who is moving forward.
Yeah, that was a follow-up question from Deb. She was wondering how you protect the wound in the aquatic bed. Alyssa would like to know, how long did it take to develop the Total Care Guide, and do you use a total joint coordinator or navigator with your program?
Yes. How long it took, and I'm trying to, it was very rapid because we had a lot of the information already created. So it was a matter of just tweaking the information and providing it to WellBe, who implemented it into their platform. If I remember correctly, it was probably about 4 months before we launched our first version of Total Care, and we did it with a limited number of physicians. We did it with just 2 physicians in one of the orthopedic groups to see how it went and to kind of work out some of the bugs. And then approximately 6 months later, it rolled out to all of our patients after we were able to tweak some things, work with Total Care on access. How do we implement? How can we make sure that who wants to get it gets it, and kind of working out those bugs. But it didn't take. It was a very quick turnaround, but we had all the information because of our joint camp already established. And I'm sorry, the second question was?
Do you use a navigator or joint coordinator?
Yep, and we do have a care coordinator. Her full-time responsibility is she does all of our community education programs for orthopedics, which includes more than just total joint replacements. She does spine, she does osteoarthritis, etc. A number of different educational programs, as well as she is the key conduit. She is the constant that we have from the patients from the time they sign up for the Total Care package through the time that they are 1 year post. So she is on the floor. She does the rounds with our interdisciplinary rounds so that they continue to see her face. We call her she's the primary therapist, and she is a physical therapist by background, but it doesn't need to be. But she's the primary person that the patients are connected with to build those relationships.
Great. From all this you implemented, did you see any effect on length of stay or readmissions? Linda would like to know.
That's a very good question. Our length of stay right now is about 3.1 days. We're still working on dropping that down. Working with the physician groups because some of it has to do with expectation setting on prior to coming in for surgery on what the patients are expecting. The other part that we are challenged by within our organization is that if patients are unable to go home and need to get into some type of assisted program, whether it be a subacute unit or a skilled nursing facility, we're sometimes challenged in this environment or in this state by making that happen as quickly as possible. And so that is skewing a little bit of our data. Our infection rates, honestly, have been very low, and our readmission rates are low related to the total joint replacements. We do have a number of patients that are readmitted, but usually for some other reason. They're having either some other procedure or something. It's a low percentage that is related to the joint replacement surgery.
Looks like we're a little past the hour, so maybe time for one more question. Jerry would like to know, are your pre-op classes or your joint camp mandatory for patients? And do patients need to have a caregiver, coach, helper assigned, set up prior to surgery? Do you require that?
Sure. No, we do not require it just because of the distance that people have to travel. We try to look at different mediums that we can provide that. So sometimes it's a phone call. Sometimes we're able to have them come here. Sometimes it's just, and depending on how quickly the surgery is scheduled, from the time it's scheduled, there's a short period of time between the time it's scheduled and the time they get here. we aren't able to do any of those. So sometimes it's a phone conversation. So no, it is not required. We highly encourage it. It is part of the process of Total Care is as they sign up for a time. We give them the times when the class is being held, and they can sign up for ones that are appropriate. But we also have young people who are working, and so it doesn't always work to come in for a class. So that's the answer to that question. Again, my memory is short. What was the second part, Megan?
Do you require them to have a caregiver or coach designated before surgery?
No, we do not require that either. We highly encourage it, but we also have team members who then will be their coach, and the therapist will coach them as they go, and we try to then work with, if family members can't be here, we then keep in constant communication with them through our social worker that is responsible for that individual.
Great. Well, that's all the time we have for today. If you have questions that you didn't have a chance to ask, please email them to info@wellbe.me, and we'll get back to you. Watch your email tomorrow for a link to the recorded presentation and a PDF of the slides. Thanks, everyone, for attending, and have a great day. And thanks, Julie, for presenting.
Thank you.